This lecture is an introduction to the cardiac system because each quarter you're going to build up on the information that you learned today. I'm going to discuss some common diagnostic tests for the cardiovascular system, what hypertension is, risk factors, complications, and how we treat it. But make sure to listen to the medication lecture because these two go hand in hand. So let's start with a quick recap on how blood flows through the heart. Remember, unoxygenated blood comes into the superior and inferior vena cava. It'll go into the right atrium, through the tricuspid valve, and into the right ventricle. Remember also that valves will close and open as necessary to prevent backflow of blood and only open when blood is going to go to the next chamber. So then the pulmonary valve is going to open to let blood into the pulmonary arteries and into the lungs for that gas exchange. Once the lungs have done their job, we will have that oxygen-rich blood coming in through the pulmonary veins, into the left atrium, through the mitral valve, and into the left ventricle. Then the aortic valve will open and push that blood into the aorta and out into the rest of the body. When we are assessing the cardiovascular system, we're going to listen to the heart, determine the heart rate, and check circulation by getting a blood pressure, checking the peripheral pulses, the cap refill, and assessing for any edema. Make sure you remember what areas you're going to auscultate for hard sounds. During health assessment, you probably used All People Enjoy Time magazine to remember the names, but make sure you also know where they're located, because depending on which area you're listening to, it'll tell us a lot about specific valves and blood flow in the heart. So we start by listening to the aortic valve on the right side of the sternum in the second intercostal space. Then we go to the left side to listen to the pulmonary or pulmonic valve. Then we'll go down to Erb's point, tricuspid, and then down one more space to hear the mitral valve. When we are listening to heart sounds, we should expect to hear S1 and S2. Remember, lub-dub. S1 correlates with the beginning of systole when the tricuspid and mitral valves close as the heart is ejecting blood out from the left ventricle and into the body. And that's why we are able to feel the pulse at this time. S2 is heard when the pulmonic and aortic valves close. This is the beginning of diastole, the time when ventricles relax and refill with blood before pushing it out again. So now let's talk about abnormal heart sounds. S3 and S4 are basically like an extra heartbeat, and they sound like a horse galloping, kind of like lub-dub-tap, lub-dub-tap. They are low-pitched sounds that are best heard with the bell of your stethoscope, and that's why we have you listen with both sides. So S3 is an extra vibration or late sound in early diastole during the transition between fast and slow filling of the ventricles. If you hear an S3 in kids or young adults, it can be normal and it usually corrects itself over time. However, if you hear this in someone over 30 years old, it's usually abnormal and it can be a sign of heart failure when the heart is not pumping effectively. The S4 is an extra sound at the end of diastole, right before S1, as you can see in the top picture. S4 will always be pathological, meaning there is an underlying disease that has damaged the ventricles and they can't pump out blood normally. Murmurs are also abnormal sounds, like a whoosh or swishing, which is blood trying to move through really narrow or damaged valves. If you look at the bottom photo, you can see what I'm talking about. Valves can become stiff or stenotic due to infection or complications of diabetes or high blood pressure, and they won't be able to open or close like they should. So if you hear a whoosh sound during systole, remember that's when blood is pushing out, you'll know it's due to stenotic valves. If you hear the murmur during diastole, that means there's a backflow of blood, which we call regurgitation. Because the aortic and pulmonic valves can't close all the way, blood will leak into those ventricles as they fill up. I put a link to a YouTube video in the notes section of this slide so you can practice listening to heart sounds. But the best form of practice is by listening to your patients in clinical and getting familiar with those heart sounds. So the more patients you listen to, the better. Moving on, let's review the cardiac conduction system and how it makes the heart beat. This is going to be very important to remember as you progress through nursing school and beyond. So the electrical conduction is going to be triggered by the autonomic nervous system, and it's going to tell the SA node how fast or slow to send electrical signals to the rest of the heart. So the SA node is the primary pacemaker of the heart, and it's found at the top of the right atrium. It's like the main commander of this ship, okay? So normally the SA node will send the first electrical impulse to both of the atria so they contract, and then the AV node will relay the signal to the ventricles to contract, and then that signal will end at the bundle branches and Purkinje fibers. When all goes as planned, the SA node gives us a nice heartbeat between 60 to 100 beats per minute. Now, if something happens to that SA node, the primary commander of the ship, the AV node is going to take over as the secondary pacemaker. It can only signal the heart to beat between 40 to 60 times per minute, though, but at least blood is still circulating. As I just mentioned, the autonomic nervous system controls the primary pacemaker of the heart. And how fast or slow the signal is sent by that SA node will depend on the sympathetic and parasympathetic response from the ANS. So, for example, if the body is in the state of fight or flight, we can see an increase in heart rate and blood pressure. If the body is able to rest and digest, the heart rate and blood pressure will decrease. Next, if the body's electrolytes are too low or too high, especially potassium, it may interfere with the electrical signals and lead to irregular heartbeats. Heart rate can also be influenced by exercise as the heart is pumping faster to meet the body's demand for oxygen. Same thing when the body is under emotional or physical stress, pain, and illness. So we're going to look at all these factors when we're assessing our patients. One of the go-to tests to assess cardiac function is an electrocardiogram, also known as an ECG, but we usually call it an EKG, I guess referencing the original German name. But anyway, the EKG was created to give us a visual representation or a picture of how the electrical signals are working in the heart. So let's break it down. Remember, the electrical conduction signals start with both atria contracting, which we call depolarization, and that is represented by the P wave. As the signal travels down through the ventricles and contract, again depolarization, we get a bigger wave known as the QRS complex. At the end, we see the T wave, which is the repolarization of the ventricles. So when those ventricles relax or recover until the process starts again. So repolarization, think relaxing. Putting all those parts together, we get a heartbeat, and the EKG will help us see the pattern or rhythm for 1 full minute. That can be printed as an EKG strip, which you can see on the right. Later on, you'll learn how to calculate the heart rate by looking at a strip like this, but for now, I wanted to show you how these beats are consistent, so it's a regular rhythm, and the heart rate is within 60 to 100 beats per minute, which tells us that the SA node is working perfectly, and that's why this is called a normal sinus rhythm. So how do we do an EKG? First, we need some electrodes, which are stickers that are placed on the patient at specific locations. Then those electrodes are hooked to leads, which are wires that are attached to a small device, like the size of a phone, that will then capture the electrical signals that are picked up by the leads and convert it into a picture that we see on the monitor. We usually do a 5-lead EKG if patients need continuous monitoring of their heart, which we call telemetry. So if you hear the patient has a teleorder, you should expect to see something like this. And I want you to know how to set this up because your nurse may ask you to help putting these on your patient. First, it's very important to stick the electrodes between bones, not over bone, because bones can interfere with electrical transmission and give a poor signal. As you can see in the photo, you're going to place two electrodes below the clavicle on the left and right side. And then you'll place two more on the lower edges of the rib cage in the same manner. The last one you'll stick in the right fourth intercostal space. After the electrodes are on the patient, you just need to attach the leads to each one. The order does not matter, but again, the location does. The leads are color-coded for this reason. So a good trick to remember where they go is white on the right, smoke over fire, clouds over green grass, and chocolate in my heart. If we want to see more angles of the heart a little more closely, we're going to do a 12-lead EKG. This is the gold standard whenever a patient comes in with chest pain because it shows any active tissue damage, like a heart attack, and where exactly is it happening. As you can see, patients will need a lot more electrodes and wires, and they need to hold still. So this is only done as needed. Once we get the EKG strip, which is very detailed, as you can see it has like 4 rows, we will then put patients on telemetry. You're not expected to do this on your own, but you can watch the video I linked here that shows how you can set up a 12 lead. So now let's talk about cardiac labs, starting with the Fab 5. So we're looking at the hemoglobin and hematocrit to rule out bleeding or anemias. We need to check the electrolytes, including sodium, calcium, magnesium, because if they're too low or too high, it will influence the cardiac electrical signals and even cause irregular heart rhythms, especially with potassium. We're also going to evaluate how long it takes for the patient's blood to clot by using coagulation tests like PT and INR, which are basically the same, or the PTT. And all of these look at different clotting factors. And you don't need to memorize the values, but I do want you to know that if you see a number lower than the normal range, it means clotting time is faster than usual, so they're at risk for developing blood clots. A higher number means it takes longer for blood to clot, so they're at risk for bleeding. Remember, we need that balance. These labs are also used to determine if anticoagulation drugs are effective. For example, we look at the PTT value to assess how well heparin is working or if we need to adjust the dose. We can also assess cardiac markers, which are enzymes or proteins that are released into the bloodstream by myocardial cells whenever there's tissue damage, like during a myocardial infarction, which is known as a heart attack. When that happens, the enzymes like the CK and CKMB will increase right away, but the protein called troponin is going to be the gold standard in diagnosing a heart attack. Like if the troponin is greater than 0.2, it could be a red flag for cardiac tissue damage, and it can also stay elevated for up to 3 weeks after. However, take into consideration that some patients with chronic diseases that affect the heart in the long run may already have elevated troponin levels due to that past injury, in which case we would have to compare their usual troponin level and see if there was a significant increase from it. So their baseline will be a little different than the standard. The B-type peptide is released when the heart begins to stretch and work harder to pump blood. So when we see this elevated, it's going to be a sign of heart failure. The lipid panel will look at the cholesterol levels. And as you can see, the total cholesterol is in bold letters, which means you need to memorize this value. So the total cholesterol should be less than 200, and it's going to be the average of your LDL, HDL, and triglycerides. The LDL is known as the bad cholesterol, and we want it to be less than 100 because it contributes to fatty buildup in arteries. The HDL is the happy, good cholesterol that should be higher than 40 to help protect those artery walls. Triglycerides should also be less than 150 because it, again, can cause fatty buildup. If you look at the test tube at the bottom, all that white is cholesterol that is just circling around in the bloodstream, and over time, that fatty buildup is going to damage the arteries and create plaque, which is going to narrow those blood vessels and reduce blood flow. When it gets to that point, we call it atherosclerosis, and that can eventually lead to hypertension and other things. Atherosclerosis will cause coronary arteries to narrow and reduce blood flow due to that plaque buildup. And after a while, it can completely block a coronary artery, and that's when patients get a heart attack. So it would be a very good idea to do an angiogram on patients as part of the cardiac diagnostics. In an angiogram, contrast fluid is injected into the coronary arteries through a small catheter, and then it's picked up by x-ray that lets us see if that fluid is flowing nicely or if there's any blockage. Like in this picture, the patient had 100% blockage, so cardiac tissue is beginning to die due to that ischemia, and it needs to be corrected immediately. Since there's a tube already in that artery, the doctor can place a balloon or a stent in there to clear that blockage and then regain circulation. So, an angiogram can be used as both a diagnostic and therapeutic tool. Now, let's channel what you learned in patho about blood pressure. And I'm sure you've seen this formula before, but basically, blood pressure is made up of cardiac output and peripheral vascular resistance. So, remember that. Cardiac output is the amount of blood that the heart can pump in 1 minute, and that amount can be influenced by heart rate. Peripheral vascular resistance is the resistance that the heart has to overcome to push blood into the body's peripheral circulation. This resistance can be affected by the blood vessel's ability to constrict or dilate, how viscous or thick the blood is, and gravity. So let's put it into perspective. Patients with diabetes may have blood vessels that have been damaged over time, so they're not as flexible as before. So then that is going to increase the peripheral vascular resistance. So it will also increase blood pressure. And that's why those patients can end up with hypertension on top of their diabetes. As we talked about in the Gerald lecture, if you don't remember, go ahead and review it. The aging process is going to impact both cardiac output and peripheral vascular resistance. The heart won't be able to contract as well, so we will have decreased cardiac output. But we will have increased resistance that only gets worse with age every year because blood vessels become stiff. So you can see how it can affect blood pressure. Now let's talk about hypertension. And just to be clear, this is the medical term for high blood pressure, and it's going to be the most common chronic disease out there. It's known as the silent killer because it doesn't have any signs and symptoms initially. But over time, hypertension doesn't just affect the heart, it's going to affect perfusion, circulation throughout the body. So, what other organs can be affected? You guessed it, all of them, including the kidneys and the brain. And that's why it's the leading risk factor for death early on. And it's also the leading cause of readmission to the hospital due to long term complications. For hypertension to develop, there must be a change in the factors affecting peripheral vascular resistance or cardiac output. Sometimes we can see both. And it makes sense based on the formula. So I like how this chart breaks down all the things that influence blood pressure. When we're assessing our patients with hypertension, we're going to look at all of these. Like, is there a problem with the autonomic nervous system? Remember, it controls the heart rate, leading back to the cardiac output. Is the patient in a state of fight or flight? And now that vasoconstriction is increasing peripheral resistance. Is there a problem with the RAS system? Remember, it will retain sodium and water, so it's going to affect blood volume that again traces back to cardiac output. So all these factors need to be considered and will even guide us with treatment. So what is considered hypertension? The current guidelines are listed in this nice and colorful table. Normal blood pressure is ideally less than 120 for the systolic number and less than 80 for the diastolic. Keyword and. They both have to be below these numbers to be considered in a normal range. If the systolic blood pressure increases to 120 and above, it's considered elevated. And that can happen when patients have pain or stress at that moment. So we're not going to diagnose them with hypertension. We're just going to monitor it to see if it goes back down. Now, if the systolic number reaches 130 or the diastolic reaches 80 and above, and it has stayed like that for a prolonged period of time, then the patient is diagnosed with hypertension stage 1. And if we don't catch or treat the blood pressure here, it will progress to stage 2 when the systolic is now 140 or the diastolic is 90 or above. We start to get a little more concerned here and intensify treatment to prevent the next stage. When the blood pressure is severely high, I'm talking about systolic being higher than 180 or diastolic being higher than 120, this is considered a hypertensive crisis, and patients need immediate medical attention because they could have organ damage. And we'll talk more about that at the end. A hypertension diagnosis will be based on the average of 2 or more accurate blood pressure measurements that are done on 2 or more occasions that are at least 1 week apart. And it can be done in the clinical setting or at home. I say accurate blood pressure readings because there are things that can change blood pressure, like the patient's position. I want you to remember the process on how to take blood pressure because as nurses, we need to know how to take it correctly so we don't misdiagnose and so we feel comfortable teaching patients how to do it at home. So make sure patients do not exercise, drink coffee, or smoke cigarettes for 30 minutes before taking their blood pressure so the vessels are nice and relaxed. Encourage patients to sit quietly. They should have their feet flat on the floor and not crossed. We want them to rest their arm at heart level. And I'm going through these steps in detail because my grandma went to a checkup recently, and the medical assistant at that clinic lifted my abuelita's arm in the air and took the blood pressure like that. So, of course, her blood pressure was super high because the blood was pushing against gravity. My mom asked the assistant why she did it that way, since no one's ever done it like that. And the assistant's response was that it was because my grandma had hypertension, which does not make sense, and it was later corrected by her primary doctor. But when my mom told me, I was flabbergasted. So that's why I want to ingrain this in your head because we don't want to create unnecessary panic from incorrect results. We want to be accurate, like when you're placing the cuff. Make sure it's on bare skin. How do you know you have the correct cuff size? The most common error when taking blood pressure is using the wrong cuff. That's why you learned in first quarter how to get the right cuff by measuring the bladder and the length, because if that cuff is too small, the blood pressure is going to be higher by 10 to even 40 points than it actually is, and vice versa. After we check their blood pressure, we also need to look at risk factors. We first have non modifiable risk factors, which are things we cannot change, like age, biological sex, ethnicity, and genetics. So, the risk for hypertension increases as people age, and hypertension is most common among adults 75 years of age and older. We already discussed why they're more at risk. And the risk also varies by biological sex and ethnicity. Men have greater risk than women, and the prevalence of hypertension among African Americans is the highest in the world, followed by Caucasians and Hispanics. Lastly, the tendency to develop hypertension can be inherited, like it runs in the family. Although we cannot predict who will develop hypertension, there's about 1,000 genetic variants that have been identified that can contribute to hypertension. And this is going to be very important when we talk about primary hypertension, in which there is no specific cause as to why some have high blood pressure, even though they have an active lifestyle, they don't drink or smoke, they eat healthy, and yet they're still at an increased risk for hypertension due to their genes. Hypertension can be classified into primary, secondary, and isolated systolic. The main difference will stem in the risk factors, so let's talk about them. The majority of people will have primary hypertension, also known as essential hypertension. But there's nothing essential about it because there's no specific cause or disease process that we can correct to make that high blood pressure go away. What we do see is that patients with specific factors are more at risk for developing this type. So, for example, patients that are older, if they're African American, or have a family history of hypertension, those are all at an increased risk, and we can't modify those factors like we just discussed. But the rest of the factors you see here are modifiable, and it's going to depend on lifestyle choices, such as stress levels, dietary choices, including increased salt intake and fatty foods, diabetes, and high cholesterol levels in the body. Remember, both of those things can damage blood vessels over time if they're not managed. Patients that smoke, drink alcohol excessively, and are obese will also increase the risk of developing hypertension. Patients that fall under the secondary type of hypertension means their high blood pressure is caused by something else, like renal disease that is going to affect blood volume, endocrine disorders, including hormones like cortisol and aldosterone. Whenever those increase due to a disease, it will affect the RAS system. If there's a tumor in the adrenal gland, for example, it can increase epinephrine and norepinephrine, and it's going to dysregulate the autonomic nervous system. Pregnancy can also increase blood pressure or even make it worse, and it's usually resolved after giving birth, but you'll learn more about it in OB. Basically, with secondary hypertension, we need to treat the underlying cause, and once that's fixed or controlled, the blood pressure will also follow and go within normal limits. Because if we push meds without fixing that cause, that high blood pressure is just going to come back. Isolated systolic hypertension is something we see much more with the Gero population specifically. Over time, their diastolic blood pressure will stay within normal limits, but the systolic blood pressure will be greater than 140. So the key words are isolated and systolic. We are still going to treat their high systolic blood pressure because patients are still at risk for complications like a stroke or heart attack, just like the other types of hypertension. Again, any type of hypertension over time can cause damage to several organs in the body, like the brain, heart, kidneys, and eyes. These are usually called target organs, and we're going to talk about how each one of them is affected if we don't manage that high blood pressure. Uncontrolled hypertension is going to eventually damage the blood vessels that perfuse the brain. They'll become stiff and narrow, and they'll also start to accumulate plaque to the point it can cause a block to the blood flow. And when that happens, it's called an ischemic stroke, which is cutting off blood supply to the brain. A hemorrhagic stroke can happen when a weak part of that damaged blood vessel will tear and then blood starts to spill out. Again, this is a consequence of a long term complication of hypertension. So that's why we want to manage it early on so that they don't get to this point. Cardiac complications are pretty straightforward. I already talked about some of them, but when the heart has to consistently work hard to overcome the peripheral vascular resistance, patients end up with hypertrophy, which means the ventricle has become thicker and it's not going to pump as efficiently as before. It has burnt out. And so there's going to be a decrease in cardiac output, and that's what we consider heart failure. And when that blood backs up into the lungs, we will even start to see respiratory symptoms. When plaque starts to build up in the arteries leading to the heart, it's going to reduce circulation, known as coronary artery disease. And the worst case scenario is when there is a complete blockage of those arteries that will cause a heart attack, just like the angiogram I showed you earlier. Over time, the arteries that perfuse the kidneys will also get damaged. As you know, kidneys are very vascular inside and out, so when circulation is compromised, the kidney function will decrease, and that's going to lead to acute kidney injuries, chronic kidney disease, and eventually into end stage renal disease. And at this point, kidneys have become smaller, and because they can't filter blood as before, we see them release lots of protein in the urine. Complications in patients' eyes are not easily noted, but think about all those tiny little capillaries that we have. Those vessels are really fragile, and when they're under high pressure for a long time, it makes sense why patients end up with damaging some of those eye structures, like the retina, and it can cause blurry vision or even vision loss in late stages. When you're checking the eyes with an ophthalmoscope, you'll see other changes shown in this picture, like they can have some cotton wool spots, which are lesions due to ischemia, and you can see swelling of the optic disc, also known as papilledema. The optic disc is a pathway that connects the eye to the optic nerve and up to the brain, so pretty important. Speaking of the optic nerve, patients are also at risk for developing glaucoma because damage to the blood vessels from the ongoing pressure will make it harder for the eye to adjust to fluid changes, and that's going to lead to increased intraocular pressure and injury to the optic nerve. Now that you know what hypertension is and the complications we're looking for and trying to prevent, let's talk about diagnostics. Obviously, we want to start with a history and physical, looking at the patient's risk factors and lifestyle habits. We need to have at least two accurate blood pressure measurements before diagnosing a patient. And then, once we know they have hypertension, we're going to do tests to rule out any underlying cause and any possible target organ damage. So, we're going to do an EKG to look at the cardiac rhythm and electrical function. We can also do an ultrasound of the heart to see the size of it, which is known as an echocardiogram. We will get some labs to assess the kidney function, like a urinalysis, look at the BUN and creatinine. We also need to look at those electrolytes, especially potassium, and of course, we want to see their cholesterol levels. It would also be a good idea to look into their eyes, which is known as a fundoscopy. Remember when we said hypertension is known as the silent killer? That's because initially patients won't have any signs or symptoms, and that's why it can be difficult for some of our patients to go and change their lifestyle or stay on their medications because at that moment they don't feel anything and they can be asymptomatic for many years. However, when signs and symptoms do appear, they usually indicate vascular damage that is now affecting the target organs we talked about. So, those late signs and symptoms will be based on which organ is compromised. Changes in visual acuity, like blurry vision, can be one of the first symptoms reported by patients, followed by headache. They can report fatigue and shortness of breath due to heart failure. Edema in the lower extremities can be seen too. The body will also try to decrease blood pressure by increasing urine output during the night, known as nocturia. And of course, chest pain can be a sign of myocardial infarction or severe heart failure. So, to prevent the domino effect of complications, all adults with hypertension, regardless of age, should consistently have a blood pressure less than 130 over 80. That's the goal. Even though that's still technically elevated, the goal isn't to make them perfect. It's to prevent patients from developing organ damage. This next point is very important. All patients are started on lifestyle modifications first. For example, patients diagnosed with stage 1 hypertension will start with lifestyle changes, not medications, and then they'll follow up to see if the blood pressure has gone down. Some patients may only need to change their daily habits, and then we'll see a drop in their blood pressure. Now, if they do need more help with medications, they will be started on those on top of lifestyle changes, so they'll continue with both. Antihypertension meds will be discussed in a separate lecture, and you should know how they work. Some will bring down blood pressure by decreasing peripheral resistance, blood volume, or the heart rate, and some have a combination of these therapeutic effects, so make sure you look at that lecture. So let's talk about lifestyle modifications. We know these interventions are going to help tremendously in their blood pressure, but first we should approach the conversation in a way that encourages the patient. We shouldn't expect them to change right away overnight, and we should avoid using scare tactics like the one you see in this comic. If the patient feels supported by you, they're going to be more willing to change and they'll hear you better. And once they're open and motivated, we want to encourage them to increase their physical activity. And your book says it can help bring down blood pressure by 4 to 8 points. So if the patient's systolic is 140, exercise can bring it down to 132. And then that exercise can also help with stress reduction. Avoiding or at least limiting alcohol and tobacco use will also help significantly, just like in any other disease. And promoting good nutrition, like the DASH diet, is really helpful because it addresses both fat and sodium intake. The DASH diet stands for Dietary Approaches to Stop Hypertension, and it's an evidence based practice that promotes high intake of fruits, vegetables, low fat dairy, and limited saturated fats. And it has been proven to decrease blood pressure by up to 11 points. So here's a list of the food groups and how many servings a day patients should have. We definitely want to limit sodium to 2.3 grams a day or less. We want them to be careful with foods that have lots of it, like frozen foods, canned foods, and fast food. It can be a little difficult for older patients because, if you remember, they have decreased taste buds. So, what do? They are going to add more salt to their food to at least taste a little bit more flavor. So, what I've typically said to my patients in the past is to start by removing the salt shaker from their dinner table so they're not tempted to put more salt. They could instead use other things to season their food, like lemon or other spices, but keeping in mind any possible interactions with some of their blood pressure medications. So, this diet can be adopted over time. Like they can start by changing their full fat dairy products to low fat, then slowly limit their intake of sweets, and they can only go out to eat maybe once versus twice a week. So, we want to encourage these short term SMART goals that are realistic and achievable for the patient. So, if the patient's hypertension remains uncontrolled, even with lifestyle modifications, your book lists 4 medications that can be started first. These are the thiazide diuretics, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. If we take it a step further, some studies recommend that African American adults start with either a thiazide diuretic, like hydrochlorothiazide, or a calcium channel blocker. And that's because they seem to lower blood pressure more effectively in this population compared to the other medications. So that's why I put 2 stars next to them. There are many guidelines for providers to know what medications to prescribe, but you just need to know that if the first line medications or any combination of them are not lowering the blood pressure as we want, then we could add a beta blocker like metoprolol. Or if they have a history of heart failure or coronary artery disease, providers may start them on beta blockers right away. Some patients will need a lot more medications than anticipated to control their blood pressure. Drug resistant hypertension is a complication that's defined as blood pressure that is above the goal despite the patient taking at least 3 medications with different mechanisms of action. Basically, they're all in different classes and at their max dose. This is shown by the red box on this diagram where it says resistant hypertension. Ideally, we want patients to be in the light green box on the bottom left, which means it only takes 1, 2, or 3 medications for patients to consistently reach the goal blood pressure, which is again below 130/80. But if it takes 4 or more medications to reach that goal, we should start looking at the underlying cause. Like maybe some lifestyle changes need to be worked on, or if there's something else going on, because it should not take that many medications to bring down the blood pressure. And we don't want to give them so many either due to side effects. So basically, resistant hypertension is also blood pressure that is controlled, but it needs 4 or more medications. So I hope that makes sense. As nurses, it's going to be very important to develop collaborative relationships with our patients, as I mentioned earlier. We will assess their blood pressure consistently and teach them how to monitor their own blood pressure at home at least once a day, and especially before their medications. We want to assess and manage any risk factors, like if they're overweight. Let's share the benefits of weight loss, how it impacts their blood pressure, making sure their cholesterol and glucose levels are under control. We can be on the lookout for complications by monitoring their intake and output for kidney function and other labs, like we talked about. We need to follow up on any new signs and symptoms the patient has reported, like vision changes. For patient education, they should reduce the amount of salt they're eating. If they're at home, they can follow the DASH diet. If they're in the hospital, the doctor usually orders a cardiac diet, which again limits salt intake. They should plan regular aerobic physical activities such as brisk walking for 90 to 150 minutes weekly, which comes down to about 30 minutes a day most days of the week, and then making sure they know when they should take their medications along with any possible side effects. Lastly, we're going to talk about hypertensive crises, and that is when blood pressure is above 180 systolic and or 120 diastolic. So either of these numbers should be elevated to be considered a crisis. There are two types. One is hypertensive urgency, and the other is hypertensive emergency. Why did they pick such similar names? I don't know. But when patients present with a blood pressure this high, they need to be treated immediately because they're either having active organ damage or they're about to. Causes of hypertensive crises can be due to undiagnosed hypertension, usually in patients that haven't had routine checkups. It can be due to uncontrolled hypertension or rebound hypertension, which is high blood pressure that comes on suddenly, typically in patients who have stopped taking their blood pressure medications. So it's like an autonomic response. Since the body doesn't have that help anymore, the blood pressure is going to excessively bounce right back up. Let's first talk about hypertensive urgency. Even though we do have that severe elevation in blood pressure, the patient is going to be asymptomatic. So they don't have any signs and symptoms. Like I've had patients with a blood pressure systolic at 185 talking to me about their day. They may just have like a little headache, but they're fine, they're dandy. Meanwhile, I'm trying to keep it cool because I know I need to bring that blood pressure down to prevent organ damage, like a stroke. So, what do we do in this situation? Typically, because we don't have any signs of organ damage yet, blood pressure can be safely lowered within a few hours with oral antihypertensives, like with an increased dose or other fast acting medications like clonidine, which is rapidly absorbed, and blood pressure usually decreases within 30 to 60 minutes. Meanwhile, we do want to assess the patient's vitals frequently, their neurostatus to catch if they're having any signs and symptoms of a stroke, and looking at their intake and output for kidney function. In a hypertensive emergency, patients are definitely going to feel it because there's active damage to the target organs. So it's going to be life threatening. The symptoms the patient reports are going to correlate with the organ that has been affected. So if they have severe chest pain, think heart attack. If they're having a severe headache or change in their mental status, think stroke. Sometimes they may even have nausea and vomiting. And if the patient is in heart failure, they'll start to have trouble breathing, which causes severe anxiety. Hypertensive emergencies account for more than 50% of heart attack cases and ultimately death. The main goal of managing a hypertensive emergency is to stop the progression of organ damage by lowering the blood pressure within the first hour, and we do it with IV medication like hydralazine. Sometimes patients will need a continuous IV infusion of beta blockers like labetalol, because after the first hour, We are slowly going to keep reducing that blood pressure over the next 24 to 48 hours until the goal blood pressure or as ordered by the provider. We don't want to rush because imagine a patient who has always had a systolic blood pressure of 160 and then we suddenly bring it down to 120. The body's going to think, wait a minute, why is my blood pressure lower than usual? So, as a protective mechanism, the patient is going to develop rebound hypertension. I'm not going to lie, these patients with hypertensive emergency require monitoring every 5 to 15 minutes. So they will usually be taken to the ICU because they not only have to treat the blood pressure with all kinds of IV drips, they also have to treat the organ damage with other medications and procedures. And later on, you'll learn how to take care of someone with an active stroke or heart attack. But for now, it's very important that you recognize these red flags and call the provider immediately when the patient is in a hypertensive crisis because the sooner we treat it, the best chances for the patient's survival.